we're at a fork in the road between the best and the worst possible outcomes.
These models help us gain an understanding of where we are in the epidemic and where we might be heading.
The initial peak, the top of the curve, may be in late spring with the end of the first wave in the summer.
We cannot prevent every death, but we must prevent all the deaths that we can.
This will be the new normal until a vaccine is developed.
A sobering message today from the federal government that this won't be over anytime soon. Hi and welcome to Power and Politics. I'm Vashi Kapelos. Ottawa released its national projections today for how the COVID-19 outbreak is expected to unfold in this country. Here's the short-term picture. By April 16th, 1 week from today, there could be 32,000 cases and up to 700 deaths. Over the course of the entire pandemic, the projections show between 11,000 and 22,000 Canadians could die. That's in the best case scenario, which factors in strong physical distancing measures. Without those measures, more than 300,000 people could die in this country. I know you're all wondering, though, how long will this way of life continue as a result? How long will businesses be closed? The forecast today shows the first wave of the epidemic right there on your screen. The most severe wave won't end until at least this summer. But smaller successive waves are also expected. As a result, this way of life is here to stay, it looks like, until at least the summer, and restrictions will have to be relaxed on a province-by-province basis. A full return to normal life is not expected, though, until the development, as the Prime Minister mentioned, of a vaccine. So what exactly does that mean for the months ahead? Patty Hajdu is the Minister of Health, and she's in the House of Commons foyer. Hi, Minister Hajdu. Good to see you.
Good to see you, Vashi.
Minister, I just want to be clear on the projections today. I understand that it's not a crystal ball, but public health officials were pretty unequivocal. They don't expect the first wave of this epidemic to end before the summer. Does that mean explicitly that physical distancing measures, travel bans, and the like, things that the federal government has put into place, are they here to stay until at least then?
I think you can interpret that correctly, yes, Vashi, that the measures that we have in place have to remain stringent until such time that we see a significant reduction in cases. And obviously, we monitor very closely the data that comes to us from all the provinces and territories. And I think the message from Dr. Tam and Dr. New today was we have to continue with all of these measures until we see ourselves safely out of the woods.
So out of that first wave is when Dr. New specifically was talking about various provinces having surveillance systems or testing systems, and then we can try and start to see what restrictions might be relaxed. As far as surveillance systems and the resources that need to be put into that or to be put into testing, those kinds of measures that will be necessary in order to try and figure out what restrictions can be relaxed when, what is the federal government doing on that?
So many things, whether it's providing technical support to provinces and territories around data and the ability to both gather data but upload the data, the financial resources they need on all of the different elements of the outbreak, but including the capacity to increase their testing, expand their lab networks, the Health Canada approvals that are coming on new forms of testing, including point-of-care testing that will allow for testing more rapidly in more remote areas. All of that kind of support is happening from the federal government. So I always say that the federal government is there to provide advice, technical guidance, money, and stuff, if you will, the kinds of materials that provinces and territories need as they ramp up their own capacities in a variety of different ways.
I want to follow up just on the testing, because I'm not sure, you used a kind of technical term about the testing. Is that the same as serological testing? My understanding is that Health Canada is reviewing that right now.
Yeah, so no, there's obviously the PCR testing that's happening right now, the testing that's happening to determine whether or not people are in fact carrying, if they're infected at the moment, if they're positive for coronavirus. That's one kind of testing. The serological study and testing that we're hoping to be able to launch very soon in Canada is actually looking at the prevalence of exposure to the coronavirus in the population, in Canadian population, and it requires actually blood samples and then looking at those blood samples to determine whether or not there is a growing immunity amongst Canadians. And that is another kind of testing, a broad way to surveil, if you will, the population and the experiences that people are having across the country, and whether or not we can detect the exposure of COVID-19 other than through positive cases of infections.
And my understanding is that that could be key to sort of removing those restrictions eventually, or figuring out how people can get back to work. I also spoke with the CEO of one of the Canadian companies producing those tests a few days ago, and he indicated that he's already shipping them, he's exporting them to the United States, but he's waiting on that Health Canada approval. How soon might that come?
So we're working very, very quickly with Health Canada people that are approving these tests, and what we need to certify is actually the validity of the test. There's no point in approving tests quickly that turn out to not be able to actually accurately detect, in this case, for example, any indication of immunity. And I will also say this is a complex area of study. So it's not so much as just having the serological test, it's what do those tests tell you? You know, we can determine if people are exposed and if they've been exposed to coronavirus, but the longer piece of that is really how long does that immunity last, and do the markers in the blood actually indicate immunity? And so virology is a really complex area of science that requires not just testing, but the ability to interpret those tests in a way that gives us confidence that immunity is actually to coronavirus and actually long-lasting.
On the other kind of testing, diagnostic testing, I want to ask you about the situation here in Ontario, because labs have the capacity to process 13,000 tests a day, but right now I think the latest tally is about 4,000 tests are being processed. Should this province, should Ontario be testing more?
Well, I think the Premier said it yesterday that he's frustrated with the level of testing and is looking at the measures that are in place in Ontario that are either restricting tests or not being able to come up to the full capacity of Ontario. On the federal side, we're there to support the province of Ontario in any way that they need that support, and we've been doing that by, for example, verifying labs and additional labs across the province and making sure that we're doing our process at Health Canada to add additional types of tests available to Ontario, making sure that Ontario has access to the materials, including the reagent, which is essentially the fluid that the swabs go into to tease apart the virus and detect the virus on those swabs. And so at the federal level, we stand ready to support Ontario as they increase their capacity.
Let me ask you a question about the framing there, because my understanding is it's test kits, so it's swabs particularly, that some assessment centers are turning people away because they don't have enough. And then it's also just the actual system itself. Like there was a backlog and certain things, the criteria for who could get tested as a result was very narrow. I'm wondering if the federal government should be the lead on it. Should the federal government be saying, okay, this is the criteria, okay, this is how many swabs you should have, this is how many tests you should be doing, in an effort to not have the sort of patchwork that we do across the country right now when it comes to testing?
Well, I think, first of all, we have to realize that the way that jurisdictional responsibilities unfold is that provinces and territories are the ones that deliver health care and also facilitate the testing capacity for a variety of different diseases across their province and territory. So in terms of guidance, that's exactly what we do, is we provide leadership through the Special Advisory Committee that Dr. Tam chairs, and it is really all the public health officers coming together to design a testing strategy for Canada that has some consistency from province and territory. Now, having said that, different provinces and territories still have the jurisdiction to do things in their own unique way, and as we see, for example, in Quebec and BC, there are jurisdictional differences. But we do know that I do know that Ontario is working extremely hard to bring up their capacity to testing. They recognize that this is the way out for Ontario as well, and I am encouraged by the words of the Premier that he's going to leave no stone unturned, if you will, to make sure that Ontario's capacity increases.
Yeah, and I don't mean to diminish that. I guess I just wonder, from someone sitting outside looking every day and listening to these updates from various provinces, there are major differences in something even as simple as testing capacity. And I wonder, when it's all said and done, if the federal government needs to be have more of a leadership role in that. I take your point on being there to support the provinces, but there really is a big patchwork.
I think, it's the nature of the way healthcare is delivered. One could say even in non-coronavirus times, there's a patchwork of ways that people receive healthcare and it's delivered across the country. There's always work to be done to make things more consistent for Canadians so that no matter which province they live, they have consistent healthcare. But listen, at this time, we have to trust in the provinces and the territories that they're doing everything in their power to bring up their capacity, whether it's to test or to treat people who have coronavirus. And the federal government's there as a trusted ally, as someone, as I said before, that can provide resources in the form of money or equipment, buying capacity, as you know, to be able to procure in larger ways across the world and stimulate domestic production, validate tests. These are all the kinds of things that my department is very focused on.
Okay, Minister, thanks very much for your time this evening. Dr. Zulfikar Bhutta is a professor in the Department of Epidemiology at the University of Toronto's Dalla Lana School of Public Health. He joins us from Toronto. Hi, Dr. Bhutta. Am I saying your name correctly? I just want to ask. I apologize.
Yeah, that's fine. It's Zulfikar. Everyone calls me Zulfi.
Okay, Zulfi. And Dr. Bhutta is correct?
Dr. Bhutta is correct as well.
Okay, thank you so much, Doctor. I appreciate you making time for us this evening. I was listening to you a little bit earlier today talk about these numbers right after they came out, and something specifically struck me in that you mentioned that the models that were put forth today don't necessarily take into account the possibility that, or the effect, I guess, of the devastation on the economy and the need that people might have to actually sustain their living or to not live this way, and also how frustrating it is for many people to be trapped inside their homes. What might that end up having? What effect might that end up having?
So that's the pragmatic reality that many societies face. I mean, particularly so in not necessarily in Canada, but in many low and middle income economies. So the impact that it might have is on the way people persist with the physical distancing and also the closure of businesses, work. All of these factors are things that have a finite limit. And therefore, one is concerned that if there is premature relaxation, either on the part of the government, because it just can no longer afford to have the entire workforce sit at home, or on the basis of people who have to go and earn a daily wage, then it could lead to a less than optimal participation in the current control measures. And if that happens, then as you saw from the model released today, very clearly, you would see the entire epidemic curve shifting towards the right and going on for a bit longer than what you would have otherwise. Nobody really wants that because the economic consequences of that are also huge. So the important thing in these models is to factor in the human factor. So they're based on mathematical projections, as is obvious, and dynamic models have those mathematical projections updated regularly based on what's happening. But to include within this the human angle, the angle that families, societies, whose children are now sitting at home and not being schooled, all of those factors have to be put in terms of ensuring that we keep people informed, that we keep this fantastic coalition that is developing between the public, private sector, and civic society going, and that we all do this together. So therefore, I welcome the release of information today, which I think is a starting point for our dialogue and discussion. And as these models evolve through participation by academia and the government, that we will be able to put in various scenarios based on what is pragmatic and possible.
What does that tell us, I guess, about the reliability of what we were presented with today? And I ask only because, and I know all the officials said it comes with a caveat. This isn't a crystal ball. But I do think today was the first time we sort of got it spelled out for us that this is going to be in place until at least the summer. How reliable are those projections?
So they're as reliable as the input data. And as you've seen from the experience of the United Kingdom and the USA, even there, the best modelers in the countries, the Imperials, the IHME, have had to revise their figures based on what's actually happened on the ground. So let's for a second just look at what these models depend upon. They depend upon, particularly the dynamic models, on assessment of what is your population at risk, and at any given point in time, how do people get infected within that population? How do they move from infection, which we know from COVID-19 may be asymptomatic in many cases, to a symptomatic illness? And then in what percentage is that illness manifest in terms of severity to land you in hospital? And within hospital, what proportion gets into intensive or critical care, and what proportion do not make it? Now, that is not cast in stone, and that we have seen change over time as this epidemic has evolved across the world. So as those figures change, some of those projections also change. As our clinical management of people when they come into hospital improves, or goes the other way around, if your facilities are not able to cope with the patient load, if you have to take decisions on who needs to get life support and who cannot get life support, we don't have the equipment, all of those things determine to a large extent which way the epidemic is going. And as has been said by Tony Fauci several times, in the United States in his daily briefings. You also see this imbalance between the figures that you see from new cases and from those who are hospitalized, and deaths are almost always the last to go down. And they continue to go up even though your caseload starts to reduce. So my read in all of this is that we have to take these models as illustrative. They give you a direction of travel, but they're not absolutely predictive. And therefore, we should do whatever we can to reduce the number even further. 22,000 deaths in Canada is a massive number.
It is.
It's totally unacceptable number. And therefore, we should do our level best to, as they say, smash the curve, bring that figure down to as low as it's possible. And we can do it. We have kept our deaths so far to under 400 something, is around 400 right now. I think we can reduce these mortality figures even further.
That's a really interesting point. And I wonder, because you had mentioned that this is sort of a starting glimpse, a starting set of models. In a few weeks, or 2 or 3 weeks, I believe health officials said they would be back in some kind of frame like that. What data points are you looking at to sort of best assess at that point on what trajectory we're on?
Absolutely. And I think, while the government may release figures in 2 to 3 weeks, I mean, this is the task of researchers, our academic centers, to be looking at this in an almost be a daily basis. And I know that there are people who are maintaining dashboards. There are people from within my own department doing this. Some of us are also involved. I'm very closely involved with prediction and projection of cases across low and middle income countries, notably in South Asia. So this is a field in which we learn all the time from evolving epidemiology and experiences elsewhere. What would be the range of estimates that we put into the model, and how those models can also be made a little bit more responsive to local contextual realities. So I think in a few weeks we will have a lot more information. Let's say if the number of deaths in Ontario or in Canada, as I dearly hope, don't go up to the figure of 700 that's been predicted by April 16th, then I think we would be on the right track to revise our figures downwards. So let's work on this together, as I said, as the thinking power and the strength of our academic centers, research centers, public health programs, and the government in Canada to look at this beast in the eye and follow it closely so that we don't keep people in the dark and we keep informing people frequently in terms of where we are going.
The other very interesting point that I thought came out of everything that was put forward today was around when things might start to change. As I mentioned, I think that's why a lot of Canadians were, hungry for that information. And the message that we received, and we had the health minister on earlier in the show, and she reiterated this, is that once that first wave is over, it doesn't mean that all of a sudden you can lift all restrictions or relax all restrictions, but it's going to depend on the province in which you're in and the kind of testing system as well as surveillance system each of those provinces has in place. Can you expand a bit on what that really means at the end of the day? So say summer, July passes and the first wave has been deemed to be over. What kind of systems would be put in place that better enable those restrictions to be relaxed?
So that's a great question, a very important question. So let me take this one by one. So firstly, we need to use this opportunity to really ramp up our information systems. And the biggest gap that we have right now is, are we testing enough people? Are we testing enough people across all age bands? Is our information around deaths related to COVID exact? There has been concern that maybe we are not capturing all the COVID deaths because some of the people who are dying either in the age brackets that have high mortality rates may not be labeled as COVID mortality if they were not tested. So we need to get our information systems right. The second important thing in all of this is that this also gives us an opportunity to improve our quality of care. So the care within our health facilities, thankfully so far, the projections and predictions in terms of the load on Ontario hospitals, where I'm currently speaking from, and elsewhere, hasn't been anywhere like the pressure that, for example, New York and New Orleans or elsewhere have faced. If we can keep that by preparing, equipping our frontline workers with the right kind of equipment, personal protection equipment and facilities, then I think we will be able to keep high quality of care for those who do require intensive care. The third is beginning to get some measure of population immunity. So someone asked me a little earlier, and I do think it's extremely important for us to get our research community to move towards measurement of population immunity on the basis of antibody testing, which will allow us to try and quantify who is at risk and who's not. And fourth, I think this is now time for us to start looking at what that transition might look like. I don't have a crystal ball myself, but what I can tell you is that we are not going to switch on and off back to the normal at that time. And as the Prime Minister said today, it might be the new normal, where we will have some restrictions, that we will be continuing to protect our elderly and susceptible population, where people with comorbidities, those who are still at risk, even though they may be younger, because they have a pathology or a disease like diabetes or hypertension, that they will need to take some extra precautions. And one more important thing, our frontline health workers, the heroes who are working in the emergency rooms and looking after these patients, they've been working nonstop. And very soon we need to look at ways and mechanisms and means of giving them a break so that we don't exhaust our existing workforce, because this battle has only just begun.
That's an interesting point, one I hadn't thought of, and they are heroes. You're absolutely right. For viewers just joining us now, I just want to point out that in the corner of your screen, you see a podium there. We are awaiting an update from the province of Alberta on the spread of COVID-19 there. We'll bring that to you as soon as Dr. Dina Hinshaw steps up to the podium. In the meantime, Dr. Buddha, I did want to also ask you, you touched on antibody testing. Serological testing. I asked the health minister about that. My understanding is that many companies have put forth proposals to Health Canada for approval. Canadian companies are exporting some of these tests to the United States as we speak. Tell me a bit about any idea why that approval process might still be ongoing here in Canada, and what prospects do you see for the potential of antibody testing?
So I think the prospects are very good. And I think the process of approval is an important one, because in all cases we need to consider whether or not a test is robust enough and that you don't get false positives and false negatives, in the sense that you're predicting wrongly if somebody is immune or non-immune. So I think some research is needed on this, its application in the field with the right categories of patients. I think within Canada, as you know, our total number of patients are still and people infected is still modest compared to many other countries, but there is no reason why this cannot be done by collaboration. And I would hope that those tests would be ready for field application and testing pretty soon. So I do stand by the possibility that we may be able to fast track one or two of the best performers in a way that we could be concurrently testing this alongside our diagnostic testing, which is principally looking at who's infected or not.
What about taking a step back, looking at the entire picture? Both the Prime Minister and the Chief Public Health Officer noted that this came to Canada later than it came in other countries. They also talked about sort of looking at the evidence in other countries and then being able to measure our own data against that data. When you do so, at this point, what is the biggest conclusion that we should be able to draw?
So I think the conclusion with that is that maybe we are at an early stage of the epidemic curve. So if you look at the curves across countries and how this rose, Canada appears to have done well by staying below the trajectory of many other countries, and that could be related to the fact that it was introduced in the country a bit later. But it could also relate to the force of infection and hotspots in many places. Where we dropped the ball, perhaps to some extent, is that we did not pick up quick enough on how susceptible our population of nursing elderly in those situations, where we could potentially have done better than we did. But at the same time, I think the government and public health officials did act very fast in Canada in comparison to other places, partly because of the experience that we had with SARS, and also because of the lessons that were quickly learned from many other places that hadn't done so. So our hope is that the curve that we are seeing, which is below the trajectory of what United States, Italy, and other places have observed, is related to the measures that we have put in place, the restriction on travel, the social and physical distancing, the recognition of infected cases and their isolation and quarantine procedures. I think all of them are paying into this. So if this pattern stays for the next 4 weeks or so, then I think we would be reasonably confident that irrespective of when this infection was introduced in the country, that we've been able to flatten the curve. But I think hold your breath for the moment, because we are still at an early stage, and some of the earlier models had predicted that you might not see an upsurge of cases in Canada until the end of April.
Okay, I'm going to leave it there. Thank you so much for your help this evening. I really appreciate it.
Thank you very much, and have a nice weekend.
You too. Hi, I'm Vashi Capellos, host of Power in Politics. See more of our show by subscribing to the CBC News channel or click the link for another video.